Hello and welcome to Ipswich, the ISGyP Live Journal Club for September 2024. This month's topic is uterine mesenchymal lesions. My name's Ron Larry and I'm coming to you live today from Marda Pathology, Brisbane, Australia, on the traditional lands of the Jagera and Turrbal people. My fellow moderators are here as well, Dr. Yan Chan in Singapore and Dr. Mahir Goody, a new moderator also in Singapore. So ISGyP Live Journal Club alternates between the Eastern and Western hemispheres. Today, you're listening to the Eastern Hemisphere edition. We go out live at 10 a.m. Singapore Standard Time on the third Thursday of each month. We try to cover a fairly comprehensive sweep through the literature over a year. October next month will come to you from our colleagues in the Western Hemisphere, and the topic next month will be cytopathology. So ISGyP is really keen to engage with trainees and junior pathologists throughout the world. And if you're listening today, we would welcome you to apply to be a Journal Club presenter. You can contact me for the Eastern Hemisphere, or in the Western Hemisphere, Dr. Natalie Benet. You might also want to consider the interesting case presentation series. These are coordinated by Drs. Pinto and Wadee in the US and South Africa respectively, and this gives trainees to present interesting cases in which they've been involved. So what do we want to get out of Journal Club? We really want to engage trainees in reading and critically appraising the current literature, as well as developing their presentation and analytical skills. So each presenter is partnered with a mentor and is supported through reading and analysing the article allocated to them, and then developing a presentation with a fairly standardised framework. So our aim is to make it an enjoyable, educational and well-supported experience for all of our participants. Now, ISGyP offers a wide range of educational events and resources, all of which are available online. You can watch these for free in real time by registering at isgyp.ca. If you're a member of ISGyP, you also have access to the full archive of slide seminars, lectures, journal clubs and meetings. It's a great resource. It's free for trainees who register with ISGyP, and membership is subsidised for pathologists from developing countries. There's also the ISGyP podcast, which is available via SoundCloud. So what's coming up on ISGyP Live? Probably the biggest thing that's coming up in the next month will be the 4th annual meeting. It's a fully virtual meeting over 2 sessions, September 28th, US Eastern Time. September 25 has this month's interesting case presentations, so 3 interesting cases, as you can see on the screen. September 25th, US time. September 26th sees Dr. Mary Kinlock from Canada presenting a slide seminar. That's the 26th, 12 noon US Eastern time. And finally, on the ISGyP podcast, there will be a new podcast going out on September 25th via SoundCloud. Dr. Angelica Hodgson from Toronto, discussing pattern-based classification systems for endocervical adenocarcinoma. Now, if you're watching live today, today's presentation is in a webinar format. So if you have questions for our presenters, please use the Q&A function down the bottom of the screen. We'll amalgamate all those questions and we'll have a discussion and questions after the third presentation at the end of the session. You can also use the chat function if you've got more informal comments or if you just want to say hello and where you're calling in from today. So we have 3 speakers today, 3 great speakers, 3 interesting articles. Our first speaker today will be Dr. Linda Logan. Linda is a breast and gynecological clinical instructor at the University of Pittsburgh Medical Center. She'll be talking about David Chappell's 2022 article, Epithelioid leiomyosarcoma of the uterus. Our second speaker, flying the flag for New Zealand, is Dr. Desmond Lim. He's from Middlemore Hospital, Auckland, New Zealand. He'll be talking about uterine inflammatory myofibroblastic tumours and a proposed risk stratification model using clinicopathological and molecular analysis. Our third speaker today, flying the flag for Australia, is Dr. Meher Gupta from John Hunter Hospital, Newcastle, Australia. Meher will be discussing Mora et al.'s recent article about pan-track immunohistochemistry in gynecological mesenchymal tumours. So with no further ado, I will hand over to our first speaker, Dr. Linda Logan. So Linda, if you could share your screen, thank you.
Sure thing. Thank you for the introduction. Okay, you can see everything okay? I'll say.
Yes, it's all good. Thank you, Linda.
All right. So yeah, so he had introduced me nicely. My name's Linda Logan. I'm a breast and gyne clinical instructor at UPMC in Pittsburgh in the States. And I'll be talking to you. Let me just minimize my Zoom thing here. Sorry. I'll be talking to you today about an article that's titled Epithelioid Leiomyosarcoma of the Uterus and Modern Outcome-Based Appraisal of Diagnostic Criteria in a Large Institutional Series. Yeah, sorry. Oh, so starting with the study design, the goal of the study was to define an outcome-determinate diagnostic pathological features of epithelial leiomyosarcomas. And the goal was to do this like retrospective single institutional study and use some IHC and molecular to review and perform to ensure that the tumors are epithelioid morphology, and then to perform a follow-up analysis of disease outcome. Now, the biggest kind of point of this study was the first bullet point I have on this slide. And therefore, the IHC and molecular review didn't really contribute too much to this paper, so I'm not going to go into great detail of that. So this article was the retrospective analysis was reviewed July 1989 through April 2020 at Brigham and Women's Hospital in Boston, Massachusetts, in the States. Slides were initially reviewed by a single gynecologic pathologist, and he looked at the microscopic features, assessing the morphology of the tumor, whether it was, epithelioid, myxoid, or spindled. And he had these 4 points that he really made a point to say that he kind of kept track of, and that was the nuclear atypia, mitotic count, the necrosis, and the kind of infiltrating border, or did it not have an infiltrating border, just kind of the overall look of it. And of these tumors, the ones that had epithelioid or pleomorphic morphology were reviewed by a second pathologist. So all the tumors that didn't have this morphology were not reviewed, and they just weren't included in this study. Pseudoepithelioid appearing tumors were excluded, and we'll get into that in a second. And then E-stem cases were included, and leiomyomas as well, just to review them and make sure we weren't missing an epithelial leiomyosarcoma in this group of tumors. And the large IHC panel was evaluated in cases where the slides and blocks were available, so not all cases had IHC or molecular done on them. So what did this paper tell us? So 1,177 leiomyosarcomas were reviewed, and of those, 81, which was about 7% of them, were characterized as epithelioid. So not a huge percentage. However, they're a very important tumor to be aware of. And the clinical characteristics of this tumor, it was interesting, I thought. The average age was 55, and the tumor size was actually quite large at 11.6 centimeters. Notably, the tumor size was greater than 5 centimeters in all of these lesions, and often most of them had necrosis. And other pathological characteristics were that epithelioid cell component had to make up at least 50% of the lesion, and they made a strong point to say that. And they had to have, at least, atypia, if not marked nuclear atypia. And the average mitotic count was 35 in the 2.4 millimeter squared field. So that was quite a lot. That's a very brisk mitotic count. And LVSI was present in about 50% of the cases. Now, 142 leiomyomas were reviewed, and none of them were recharacterized as epithelioid. And it was interesting because LVSI, their criteria was kind of yes or no, was it present? Not really a spectrum or a threshold. So there wasn't really kind of an in-between category here. So it was either yes or no, which I find interesting. And then also, this paper kind of showed if you increase the risk, or if you increase the mitotic count, kind of sorry, I'm blanking. If you increase the mitotic count, and you might miss some of the lower mitotic count epithelioid and leiomyosarcomas. So if that's the diagnostic criteria, we have to be careful that we're not missing very bland lesions that could be still categorized as this lesion. So this picture on the left here is showing what these lesions look like grossly. So they're a soft and fleshy tan tumor. They have areas of necrosis and central cavitation, as you can see in both of these photos. And then on the right-hand side, this paper made a strong point to kind of determine what was their criteria for calling epithelial morphology, like what did the cells have to look like? And the definition was they had to be polygonal or round, they had to be relatively pink and eosinophilic, and round to oval nuclei, sorry. And so this is just some of the photos that are a nice representation of what these screeners were looking for to call these epithelioid. And then notably, they did exclude pseudoepithelioid appearance, which is letter C. And that's just a nice picture of it showing the cross-sectional fascicles, which can appear round. And this next picture on the left-hand side is showing tumor cell necrosis, and it was abundant in most of the lesions, as well as nuclear atypia. And C is showing kind of a 2+, and D is showing severe 3+, and E is showing pleomorphic, which was 4+. That's how they created it. And the mitoses were quite atypical and focal sometimes, and F is just showing like a nice picture of that. The next diagram to the right is showing kind of the different types of infiltrating edges that these tumors had, the different range. And on the left-hand side, it's kind of more well circumscribed. On the right side, letter B, it's kind of nested. And C, it's kind of showing like vascular space invasion, the LVSI that we were discussing. And I think, that's kind of what they're going for on that one. And then on letter D, it's showing atypical mitotic figures that they were often relatively observed. So that was a nice review. So getting into kind of the overall survival and the statistics, and as we all know, statistics can be challenging and verbose. And so I just kind of posted here the most important outcome, I guess. And this is just kind of showing the disease-free survival over the course of about 5 years with the different, morphology and the stage, LVSI and mitotic count. And as you can see, the red on the top left is the epithelial morphology, and it's decreased the 5-year survival to 35%. And the stage, as you advance in stage from 1 to 3 or 4, your 5-year survival goes down as well. And LVSI being present decreased your 5-year survival, and then having mitotic count greater than 10 per 10 high power field also decreased your overall 5-year survival. And this was the primary outcome was measured, and it was defined as the interval from the first pathologic diagnosis to death by leiomyosarcoma. And they did this on cases that they could follow through. And the survival analysis was performed using a Kaplan-Meier method, and survival curves were compared using the log rank test, as well as the 2K method, or TUKE. I have a hard time saying that. And then Cox proportional hazard regressions was used to kind of do the hazard ratios and multivariate analysis. So getting to the end here, a couple more minutes, the importance of this study was kind of, historically, leiomyosarcomas are mostly dependent on, the FIGO stage, and other factors have shown to be prognostic, kind of the ones we listed earlier in the presentation. However, this is very rare. It still represents about 2 to 7 of these lesions. And since they have a decreased overall survival, they're very important to make sure you can identify. And with these taken together, this retrospective analysis kind of determined a nice histologic criteria that's easy to follow for the average pathologist, I thought. And that was basically just, keeping track of the nuclear atypia, mitotic count, and necrosis, in addition to the couple other things that we got into earlier. And utilizing this diagnostic criteria, one should be able to separate epithelioid from spindle leiomyosarcomas, including that pseudoepithelioid appearance that I showed in that figure, and importantly, other leiomyosarcomas with clear cell change. And so in the right-hand side here, it's showing kind of the number of cases, and kind of when you have mitotic count only, necrosis only, and then more than one, so up to 2 or 3 features here. And often, the WHO tells us, we need 1 feature. This paper is saying that we should have 2. And at first, you think, oh, if you have 2 features, are we going to miss the cases that only have 1 feature? But this figure here kind of shows that in the cases that had like no mites or very low mites, they often had a second feature anyway that would get you to diagnosis lesion. So that's kind of what they're saying in this table. And that's what I wanted to say here. So strengths and areas for improvement. So it would have been nice to have a couple gynecologic pathologists screen in the beginning, rather than just having one. Although we can trust, our colleagues, it'd be nice to kind of have maybe like a MDC kind of you could get together and discuss the initial screening just to make sure that we're all on the same page for what we're, starting with, because that's where your study starts. So we're just trusting that this pathologist screened this well. And then an additional study that maybe emphasized the molecular profile, which we didn't get into, would have been nice. And it should probably be done because it didn't add much to this study. And the internal data that they were using, as I'm saying lower in this PowerPoint slide here, is that it was kind of an in-house data set. It's difficult to find data to compare with. It's not published data. It's kind of in-house data. And so that's kind of also an area of improvement. Maybe we could do the same study with published data. And then defining the diagnostic criteria, I thought was a strength. I think it's a helpful tool for pathologists. I think it's easy to follow when you're trying to diagnose these tumors. And I already mentioned the last point here where the WHO states one or more worrisome features, and kind of wondering if making this more stringent, if we're missing any of these lesions. And finally, how do we apply this? So can we apply this study to everyday practice? I think so. I'm a relatively junior pathologist. I'm a fellow. And so sometimes these types of papers can be challenging because I've only seen so many things, but I thought that this paper was really easy to follow. And I feel like I could use this paper as a landmark study potentially to like refer to when I'm looking at these complicated cases. They had nice tables and nice pictures, and it was, I thought it was easy to use as a resource. And it kind of provides pathologists with this framework for diagnosing these lesions and a differential to think about, including the E stump that I didn't really talk much about, but they go into detail about that and all the different features here. So it kind of gives us an understanding regarding the prognosis of these lesions when we're making this diagnosis. And that is all I have prepared for you.
Thank you very much, Linda. So we'll just roll on to our second speaker. Our second speaker is Dr. Desmond Lim. So Desmond, if you could share your screen, thank you.
Great. Hopefully that is shared.
Yes, that's great. Thank you.
Great. I'll get started. So thank you for that. I'll be talking about a paper titled Uterine Inflammatory Myofibroblastic Tumors, proposed risk stratification model using integrated clinical pathologic and molecular analysis by Nicholas Ladwig et al., published in the American Journal of Surgical Pathology in February of 2023. Very briefly, inflammatory myofibroblastic tumors, or IMTs, are fibroblastic/myofibroblastic spindle cell lesions accompanied by an inflammatory cell infiltrate. They have a wide anatomical distribution, and they are rare in the uterus, and diagnosis is often aided by ALK positivity on immunohistochemistry. While most IMTs are benign, a subset will develop local recurrence or distant metastasis at times years later. I've got a list of proposed high-risk features here. The morphologic features are what have been proposed for uterine IMTs, while the IHC molecular features are from other sites because not much molecular has been done on uterine IMTs prior to this paper. So the features are having an older age, large tumor size, infiltrated borders, the predominance of a myxoid morphology as opposed to a fascicular morphology, severe cytologic atypia, necrosis, increased mitotic activity, ALK negativity, RAND PB2 ALK fusion, P53 expression, and MDM2 amplification. The aim of this study was to study the underlying genetic alterations of uterine IMTs, assess potential factors that contribute to likelihood of aggressive behavior, and to use all this to develop a clinical pathologic risk stratification model. Now, in this presentation, I will highlight the key parts of the paper, as the study itself is quite large. This was a retrospective study done at the University of California, San Francisco, looking at cases diagnosed as uterine IMTs based on the WHO classification system, 5th edition. And the H&E and IHC slides were reviewed by 2 pathologists with gynecologic expertise. However, due to the small number of cases, a literature review was performed, and overall 2 studies / statistical analyses were performed. Firstly, with the data from the present cohort, and secondly, on the combined series of the present cohort and the previously reported cases from the literature. IMTs were split into either having aggressive behavior or no aggressive behavior, and the inclusion criteria for aggressive behavior was extrauterine disease at time of presentation, local recurrence, and distant metastasis. So overall, in the present cohort, 11 cases were identified, 6 non-aggressive, 5 aggressive, and from the literature, 41 cases were identified to give a total of 52 cases, 30 non-aggressive, 22 aggressive. The variables collected from the present in-house cohort were the patient's age at diagnosis, the percentage of compact, vesicular, and myxoid growth patterns, mitotic count, presence of epithelial ganglion-like cells, the degree of inflammatory infiltrate, necrosis, the presence of lymphovascular and space invasion, the tumor border, whether that was well circumscribed or infiltrative, and nuclear atypia, graded as 1 to 3 using criteria from another paper, essentially equating to mild, moderate, severe. IHC was performed, specifically ALK, P53, and P16. P16 because a complete absence is correlated with CDKN2A deletions. Furthermore, ALK, FISH, and capture-based next-generation DNA sequencing, or NGS, were performed, and whole transcriptome RNA sequencing was performed on cases with no fusion identified by DNA sequencing. The univariate and multivariate statistical analysis was performed again on the current cohort, and it was repeated on the combined series of 52 cases, and the risk stratification model was developed using logistic regression. This table shows the results of the statistical analysis for predictors of aggressive behavior. On the left is the present series, and on the right is the combined series. Focusing first just on the present series, the statistically significant factors were having an old age of diagnosis, having a higher percentage of vesicular morphology, moderate to severe atypia, a high mitotic count, and infiltrative borders. The key thing to note is that the size of the tumor was found to not be statistically significant. This really large table just summarizes the IHC and molecular findings in the present cohort. With P53 IHC, all non-aggressive cases showed wild-type staining, whereas 2 aggressive cases showed aberrant staining. With P16 IHC, all non-aggressive cases again showed no aberrant staining. And with the aggressive cases, 2 again showed aberrant staining, 1 showing strong diffuse staining, and 1 showing aberrant absent staining. ALK IHC was positive in all cases. ALK FISH was positive in all cases when performed. And this is just the list of the ALK fusion partners with but no significant pattern noted. The bottom left corner shows that none of the 6 non-aggressive IMTs harbored additional molecular alterations outside of the ALK gene fusion. It also shows that there were no copy number aberrations in all but 1 case, which showed segmental loss of chromosome 3p and segmental gain of chromosome 7p. On the other hand, all aggressive IMTs harbored molecular alterations and numerous chromosomal copy number changes in addition to the ALK fusions. The bottom right corner shows the range of molecular alterations seen in both the primary tumors and their metastases. And this bottom row highlights the accumulation of numerous segmental chromosomal gains and losses in the aggressive cases, which is not seen in the non-aggressive cases. Going back to this table now, focusing on the combined series, the key differences here are that a larger tumor size is now statistically significant, while the percentage of vesicular pattern is no longer significant. And using this data, a risk stratification score was developed with 4 factors. 1 point is scored for each of these factors, then being age greater than 45, tumor size of 5 centimeters or more, 4 or more mitotic figures per 10 pi power field, and infiltrative borders. A score of 0 puts the tumor in the low risk category, 1 to 2 is intermediate risk, and 3 to 4 is high risk. This table shows the 52 cases broken down by their risk score. There are no aggressive cases with a score of 0, and there are no non-aggressive cases with a score of 3 or 4. Scores of 1 and 2 have a mix of aggressive and non-aggressive IMTs. Of interest, looking at score number 1, there is one case here with aggressive behavior, but this case had incomplete data. Specifically, the borders weren't assessed. This case potentially could have had a score of 2 if the borders were infiltrative, and if so, that would mean that all cases with 1 point would be non-aggressive. However, the data available cannot exclude the possibility of aggressive IMTs with 1 point, and I'll get to the relevance of that later. Overall, a 2-step risk stratification model is proposed for predicting clinical behavior. As mentioned before, 0 is low risk and 3 or more is high risk. But for the intermediate risk IMTs, molecular testing is advised. And if only an ALK fusion is identified, the tumor is low risk. And if additional alterations are seen, the tumor is high risk. One of the key things I noted from this paper is that insufficient data, especially from the previously reported cases, may have impacted the risk stratification scoring system. For example, the previously reported cases lack the comprehensive molecular studies. They had a shorter follow-up duration, an average of 3.9 years versus 11.5 years in the current series, which is important as recurrence or metastasis can occur years later. And there is incomplete data due to previous studies not focusing on certain factors. This is especially the case for the percentage of morphologic pattern, which was statistically significant in the current series, but not the combined series. This table is just from the paper. I'm showing all the data from the 52 cases. And what I've highlighted in red is the missing data, which again, most notably is the percentage of fascicular morphology, but also LVI. The outcome of the study necessitates comprehensive sampling of the tumor interface to evaluate for infiltrative borders. However, the paper itself shows that this can be a challenge as tumors can be received morcellated. And in terms of TP53 mutations, it has been previously suggested that aberrant P53 staining was not seen in fusion-driven uterine sarcomas. Thus, a P53 abnormality makes you think of a leiomyosarcoma. This is the first study to find that aberrant P53 staining is present in a subset of uterine IMTs, and so leiomyosarcoma is no longer the only differential that should come to mind, or the key differential. In addition, the study findings show that while not always present, aberrant P53 staining can be an indicator of aggressive behavior. Only 2 cases from the combined series showed LVI, but both of these cases showed extrauterine disease at presentation, and so it didn't make it into the final risk scoring system. The paper acknowledges this and acknowledges that it would be logical to infer that the presence of LVI would make the tumor aggressive regardless of other findings. In terms of the strengths of the paper, this is the first study to demonstrate that aggressive uterine IMTs harbor additional molecular alterations beyond an ALK fusion. The paper provides detailed data using supplementary tables that can be accessed digitally. For example, they show all 500 genes using the NGS assay, and they show the statistical data from their regression modeling. And as mentioned before, there is a relatively long follow-up period in the present series. In terms of areas for improvement, firstly, no time frame was provided for their retrospective review. They don't specify if the cases were consult cases or in-house, which is important as this can skew the data towards more complex or aggressive cases if they were all consult cases. The mitotic count is given in 10 high power field, but I felt it should be given in square millimeters. And finally, MDM2 amplification was suggested as a high risk factor, but this theory wasn't really tested with IHCs. In terms of the applications of the findings, this paper gives insight into the prognostication of IMTs, and this can guide follow-up management. One example of this is being able to offer myomectomies in low-risk cases as opposed to a hysterectomy for women who wish to preserve their fertility. The findings can sort of help save money if you were to use this by only performing molecular testing on intermediate risk cases. From the combined series, 23 out of 52 cases, or 44% of cases, would require NGS, but this number improves to 15% if only a score of 2, as mentioned before, required NGS. And finally, one can take away that P53 and P16 can be performed routinely for the workup of uterine IMTs. Thank you.
Thank you, Desmond. We'll move on to our final speaker for today. Our final speaker today is Dr. Meher Gupta from John Hunter Hospital in Newcastle. So, Meher, can you please share your screen? Thank you, that looks great.
Sorry, I was just unmuting. Thank you. Yep, so my paper is Pan-Track Immunohistochemistry and Gynecological Mesenchymal Tumors, Diagnostic Implications and Pitfalls by Maurer et al., which was published electronically at the end of last year, but in print at the start of this year. So I'm just going to go through a bit of background because these are rare tumours and they are molecularly defined tumours. So NTRK stands for neurotrophic tyrosine kinase receptor, and they are genes that encode for TRK, tropomyosin receptor kinase receptors. So TRK are a type of tyrosine kinase receptor, and NTRK's the gene that encodes for them. So NTRK generally plays a key role in embryology in neurogenesis, but in adults it also helps with general neural function and neural plasticity. And the downstream signaling of the TRK receptors are to do with cell growth, survival, and proliferation. So the P1-3K, AKT, mTOR pathway, the RAS-RAF pathway, and the PLC, DAG, PKC pathway. And there's 3 NTRK genes, 1, 2, and 3, and they code for 3 TRK receptors, A, B, and C. So there's generally 2 categories of NTRK-associated tumours. There's tumours that are where NTRK fusion is present in a high frequency, and it's sort of a defining feature of those tumours. So, for example, secretory carcinoma of the salivary gland and breast, infantile fibrosarcoma, and NTRK rearranged uterine sarcomas, which we'll be talking about today. And then there's neoplasms where NTRK fusion is present in a low frequency, and it's sort of part of a pool of fusions that are present or gene alterations that are present, but it's not a defining characteristic of the tumor. So, for example, lung, melanoma, and colorectal cancers can all have these. And the reason it's important is because there are TRK inhibitors. So this is a screenshot from an Australian consumer information guide about the drug larotrectinib, which is a TRK inhibitor that's been approved in Australia and worldwide for these criteria, for these criteria. So for the treatment of adult and pediatric patients with locally advanced or metastatic solid tumours that have the NTRK gene fusion, that are metastatic, or where surgical resection is, or when tumours are unresectable, or when they've progressed following treatment, or there's no other treatment available. And these cancers can appear in many different parts of the body, so these drugs are known as tissue agnostic drugs. So moving on to our NTRK rearranged sarcoma of the uterus. So in the WHO 5th edition, this is under the title NTRK rearranged spindle cell neoplasm emerging. It was initially described in 2011 by Mills et al. As a neurofibrosarcoma, and then the NTRK rearrangement was ascribed to it in 2018 by Chiang et al. It's a rare entity, so less than 50 cases have been reported worldwide to date. And it tends to affect young premenopausal women, generally the cervix over the uterine corpus, and NTRK1 fusions are the most common. So this is what it looks like morphologically and immunohistochemically. So you have these monomorphic spindle cells arranged in sort of haphazard fascicles. There can be a scattered inflammatory background. So at this stage, it sort of gives a fibrosarcoma sort of appearance, or at least some sort of sarcomatous appearance. The CD34 is positive, the S100 is positive, and Pan-Track is positive as well. And we'll see later with the results of this study that the positivity can vary. So at this point, you might be thinking it's some sort of soft tissue tumor of the uterus. So then your other IHC stains in your workup are quite important. And for NTRK rearranged sarcomas, the SMA and Desmond are negative, so rules out sort of smooth muscle lineage. And ER-PR are negative, and CD10 is negative as well, which is important for ruling out the stromal sarcomas. So moving on to our study. So Pan-Track IHC is the most widely available and cheapest screening tool for these tumours, but the sensitivity and specificity can vary. So some NTRK rearranged sarcomas have negative Pan-Track IHC, and in one meta-analysis of all NTRK rearranged tumours, so not just the uterine sarcomas, up to 18% of them had negative Pan-Track IHC. And on the other hand, some other sarcomas without the NTRK fusion can have positive Pan-Track IHC. So in one study, up to 91% of high-grade endometrial stromal sarcomas had positive IHC. So regardless of the IHC result, NTRK rearrangement needs to be confirmed molecularly. So this study was basically trying to see if there is a role for Pan-Track IHC in the routine diagnostic setting of NTRK rearranged sarcomas. And their aims were to investigate Pan-Track IHC expression across a large cohort of mesenchymal tumours, correlate this with the molecular data, and evaluate the utility of Pan-Track IHC in distinguishing NTRK rearranged sarcomas from its mimics. So this is a retrospective review. It pulled out 473 gynecological mesenchymal tumours over a 30-year period. Most were from a single institute in Europe, but some authors did contribute cases globally as well. So they had 461 cases without known NTRK fusions, and they had 12 known NTRK rearranged sarcomas. Tissue was evaluated largely using tissue microarrays, which I have a photo of in the corner there. It's basically where they take cores of tissue from the paraffin blocks, and they can put many more of those cores on a single slide. It's a widely used technique in research to just be able to view slides more efficiently. So most samples were evaluated using that, and a lesser group were evaluated using whole tissue sections. And then Pan-Track immunohistochemistry using this EPR 17341 ABCAM antibody clone, which is quite a commonly used clone, was used, and they graded the intensity of staining as low, moderate, or strong, and the location of staining, whether it was nuclear or cytoplasmic. The definition for positive staining was greater than or equal to 1% of tumour cells in any location and of any intensity, which is a standard definition that's been used in the literature. And diffuse staining was greater or equal to 70% of tumour cells. Molecular techniques of RNA sequencing or FISH break apart probes for the labeled for NTRK were used to confirm molecular status in Pan-Track positive cases. So not every case had molecular done on it. So the results. So out of the 12 known NTRK rearranged sarcomas, 11 showed 11 showed Pan-Track IHC positivity, and of the 461 tumours without known NTRK fusions, 11 showed positivity. And of those, it was 3 low-grade endometrial stromal sarcomas, 7 high-grade, and 1 undifferentiated uterine sarcoma. So this is a busy table, but we'll just go through it. So this is just showing the 12 known NTRK rearranged sarcomas, and that 92% or 11 of them were positive. These are all the entities that were included in this study. So you can see most of them are like adenosarcomas, endometrial stromal tumours, and sarcomas, and the smooth muscle tumours as well. And you can see out of all of those entities, the only ones that showed Pan-Track IHC positivity were the low-grade endometrial stromal sarcoma, high-grade endometrial stromal sarcoma, and undifferentiated uterine sarcomas. This is a table breaking down the staining profile of those 12 known NTRK rearranged sarcomas. So as I said, 11 were diffusely positive for Pan-Track IHC. Of those 11, most of them had strong staining, so 8 out of the 11. 2 out of the 11 had moderate staining, and only 1 had weak staining. All of them showed cytoplasmic expression, so none had nuclear staining. And most of them had this TPM3 NTRK1 fusion, with less common fusions, particularly involving NTRK3, also recorded. And the one case that showed no staining had the SPECL1 NTRK3 fusion, which is an unusual fusion. So this is from the paper showing the Pan-Track IHC expression and morphology of a subset of those known NTRK rearranged tumours. So A is showing diffuse moderate staining, B, diffuse strong staining. C, the cells that aren't staining in C are actually normal smooth muscle cells, and the cells that are staining are quite diffuse and moderate staining. They're infiltrating through the normal cells, so that's still diffuse moderate staining. D is diffuse strong, and E is diffuse strong as well. F is the speckle 1 NTRK3 tumor that was completely negative for pan-Trk staining. This is the table showing those 11 tumors that didn't have a known NTRK fusion, but did have positive pan-Trk IHC. So out of the low-grade endometrial stromal sarcomas, you can see only one, the one that had 90% staining. That would be the only one that would qualify as diffuse staining by this definition. The other two weren't diffuse, and none of them had strong 3+ staining. The high-grade endometrial stromal sarcomas, even though 7 of these were positive for pan-Trk, again, only 2 of them would have met the criteria for diffuse staining. And again, none of them had strong intensity staining. And the undifferentiated uterine sarcoma, again, had non-diffuse, non-strong staining. And you can see even when molecular analysis was done, it was inconclusive in 2 cases, but in the others, no NTRK fusions were detected, even when RNA sequencing or FISH was done to detect them. And this is similarly just showing the pan-Trk expression and morphology in those tumors. So A is showing patchy, weak staining. B is showing focal weak staining. C is patchy, moderate staining, but it's showing a nuclear pattern of staining. D is patchy, moderate intensity staining. E, diffuse, moderate intensity staining. And F, patchy, moderate staining, again, nuclear staining. So you can see overall, even though there is sort of some diffuse staining and some moderate staining, overall it looks, it gives the impression of being a bit less diffuse and less strong than the pan-Trk, than the NTRK rearranged sarcomas which had the fusion. So overall, the results of this study support the preceding literature that most NTRK rearranged sarcomas of the gynecological tract display diffuse, moderate to strong cytoplasmic pan-Trk IHC staining. But occasionally, NTRK rearranged sarcomas can have a negative pan-Trk IHC, and the exact mechanism of this is unknown. It's thought that there might be pre-analytical variables that cause a conformational change in the epitope that the antibody of the IHC would bind to, which stops it binding to it. And they're normally associated with the tumors that either have unusual morphology or unusual fusion. So for example, the NTRK3 rearranged tumors can often have this phenomenon happening, and that was the case in this study. The other thing is that other mesenchymal neoplasms can be pan-Trk IHC positive, even though they don't have an NTRK rearrangement. Normally, it's high-grade endometrial stromal sarcomas, which can have a variable amount and intensity of staining. And it's hypothesized that this is due to NTRK3 upregulation in Yahweh and BCOR altered tumors, which soft tissue, there's been studies into soft tissue sarcomas with the Yahweh and BCOR alterations, and they have NTRK3 upregulation. In this study, there were no pan-Trk IHC positive smooth muscle tumors, though they have been reported in the literature. There's never been a reported adenosarcoma with pan-Trk IHC positivity. In this study and elsewhere, there's been no reported uterine IMTs with pan-Trk IHC positivity, but there have been IMTs in other sites with IHC positivity. And some of the other new molecularly defined uterine mesenchymal tumors can show weak positivity. The clone that they use, the EPR17341, appears to have the best performance based on positivity rate. So it'll generally pick up the most number of cases, but it can have some false positives as well. But significant variation does exist amongst the clones, and not every study states which clone they use, so it can be a bit hard to compare between studies. So their conclusion was in the correct clinical and morphological context, so the right location, the right morphology, and the right other staining profile. And then with the correct pan-Trk staining profile of being diffuse and moderate to strong, then it's very likely that you've got an NTRK rearranged sarcoma, but molecular studies are still required. So I thought the strengths for this study were it was quite a large cohort. It had sort of a quarter of all known NTRK sarcomas in it. And I thought they used quite generalizable like IHC machinery and clones and molecular techniques, which when looking to generalize it to day-to-day practice, I think that, yeah, it was quite generalizable. The limitations, so molecular testing wasn't conducted on every tumor in this cohort. So the true sensitivity and specificity of the pan-TRK IHC couldn't be calculated in this study because, there might be some tumors that had pan-TRK who were pan-TRK IHC negative, but did have the rearrangement, but we wouldn't know. Most IHC was performed on the tumor microarrays, which not only is that not generalizable, but there's a risk that because you're only taking a core of tissue from that paraffin block, you could be getting a non-representative sample of that tumor. But the authors of the study stated because of the 12 known NTRK rearranged sarcomas, most of them had a staining profile that they would expect for those tumors, that it probably shows that the tumor microarrays are a good way of looking at tissue in this sort of setting. The study didn't state whether one or multiple pathologists reviewed the slides or how they reached consensus about what staining profile they were reporting the slides to be. And I also found it interesting that there were no new retrospective NTRK rearranged sarcomas diagnosed, because obviously this is a new entity. And I would have thought if you're looking back at tumors over a 30-year period, you would pick up some that wouldn't have been diagnosed at the time because the entity didn't exist. So I guess it might show that IHC on maybe older paraffin blocks is maybe a bit less reliable, maybe. So NTRK for day-to-day, NTRK rearranged sarcomas do still remain a rare entity. I think that tumors that meet the morphological and clinical criteria, then pan-TRK IHC can be a useful screening tool. At the moment, there's no cutoff for when to truly suspect or what to count as positive or likely to be an NTRK rearranged sarcoma. So I think more research is needed to determine the IHC profile, whether it's diffuse, moderate to strong staining, as was found in this study. And then I think regardless, you probably still need molecular confirmation. So if your pan-TRK IHC is positive, you need molecular confirmation. I think in a case where, the morphology fits, the clinical context fits, and there's no other IHC to explain the tumor, to point you in another direction, then, but the IHC is negative, I think even then you probably do molecular to confirm if you've got no other explanation for the tumor. But tumors that I think, don't fit the criteria, or where other IHC, like the smooth muscle markers or CD10 or something is positive, then there's probably no utility in pan-TRK IHC due to the risk of false positivity. And those are my references. Thank you.
Thank you, and thank you to all our three speakers. I'll now ask our panel members and our speakers to switch on their cameras, and we're just going to have a brief discussion about the papers, and if the panel members have any questions that they'd like to raise. At the moment, we don't have any questions in chat, but I'll be keeping an eye on the Q&A function as well. I'll lead off. Linda, I think I like the way you said that your paper was something you're going to put in your backpack, because it's just going to be really handy when an unusual epithelioid smooth muscle lesion crosses your desk. What do you think was the most important thing you got out of reading that paper when it comes to practical applications? And when you're reading a paper about an entity you don't see very often, were there any surprises?
That's a great question. So I think the first part, so the surprise is what's in my mind right now. So the surprise to me when I was reading the paper, the surprise was kind of like they're talking about these lesions could be bland and most of them aren't, but some could be, but then most had lots of mitotic figures. And so to me, it was kind of like am I looking for a bland lesion or a very obvious lesion? So it's kind of like I didn't really know like what the in between would look like. And so the surprise to me was just it felt like it was a very obvious lesion or a very bland lesion, but no in between for, morphology. And that I could see being a challenge, when you're practicing. So that was kind of my feeling. And then remind me what the first part of your question was. I'm sorry.
So from a practical sense, from a practical point of view, when you're next encountering an epithelioid smooth muscle lesion, what's the most important point you've taken away from this?
Oh yeah. So I would say the most important point would be just not to miss them. They can look like other things and other things can look like them. And I think the whole point of this paper was to use their kind of morphologic criteria so you don't miss them because they're easily kind of mimickers, and things can mimic it. So I think that was my biggest takeaway was, never kind of close the case before you've thought of all diagnoses, even if it's just a 7%. Not very common, but it's just yeah, I would say the biggest thing was that it can mimic or things can mimic it. So here's a couple things that you can do to try to not miss such an important lesion that has a decreased survival rate.
As you mentioned, as part of their study, they went back over their 30 years and tried to find E-stumps, so epithelioid stumps, and I think they found a grand total of 3.
3.
And then, as you said, they went through a series of consecutive lyomomas looking for epithelioid lyomomas and didn't find any over a couple of hundred. So obviously, it illustrates the rarity of epithelioid smooth muscle lesions. But I suppose if you can only find 3 E-stumps over 30 years, and their follow-up was pretty limited, I suppose, do they really exist, do you think?
I think it's one of those categories of uncertainty. And so it's like it doesn't have enough features to call it this, but it has too many features to call it just benign. So we're going to call it this thing to make sure it gets more follow-up or it makes kind of flags the case so the like clinician doesn't just write it off as benign. So that's kind of how I took that away was, it's kind of like that in-between diagnosis and we don't really know how they behave and they might behave benign or they may behave malignant. So just to keep an eye on them.
Yeah, I think it's difficult when you've got 3 over 30 years to predict how they're going to behave. So, yeah, thank you. Desmond, thank you for your talk. I suppose one of the things about having Journal Club in our particular hemisphere, and one of the reasons we've been keen to do this, is because we talk to a different audience than the Western Hemisphere Journal Club. And
Right.
one of the nice things about your paper was when you went through the algorithm of risk stratification was the ability to triage out cases where molecular was not going to be helpful. So you could really focus your resources. So my question to you is, in your current setting, do you have access to the resources you would need to fully categorize an intermediate IMT?
Yeah, look, that was one of the biggest thoughts I had on my mind as I was going through this paper. In New Zealand, and I guess Auckland in particular, almost all of anatomical pathology is a public government funded service. And so, with every test, every IHC, every fish, it's taxpayer money that we're spending. We don't send very many cases at all for molecular studies. They're typically reserved for very difficult sarcoma cases where we really have to justify that the money spent will, change immediate management to this patient. And so again, while going through this paper, they're wanting us to use molecular to prognosticate. And look, that's all well and good to say, look, we have the data to support why this is important. It's just in our country, at least, that's thousands of dollars. I think it's upwards of 5,000 plus to send cases away to other countries because we don't really have NGS services here based in New Zealand. We send them to Australia, we send them to America. I just didn't know how feasible that would actually be. Now, of course, uterine IMTs aren't super common, but again, it's just that feasibility of spending that money. Yeah, that thought crossed my mind. So look, while we have the services at our disposal, we use it sparingly. And unsure, look, I probably can have a discussion with my sarcoma consultants about whether they think this is justifiable use of molecular, but we're limited, and it probably wouldn't be applicable to a country our size, much less smaller countries and smaller laboratories.
Now, in your paper, you had their own cohort and the literature cohort. Could you get much of a feel about how aggressively people were treating uterine IMTs and whether or not that prognostic data might feed into treatment decisions in some settings?
Yeah, that's a good point. Look, they do go through, obviously, they list everything that each case was managed with. Most of them had hysterectomies. I guess when they actually didn't talk about whether cases were biopsied beforehand. You'd assume they would be. But I guess they go to, for all these cases, for hysterectomy for the most part. I think, if I recall, there were some myomectomies, but I think the majority were hysterectomies. There was, interestingly, one case where the tumor was supposedly expelled during childbirth. So not sure why they didn't go back and form a myomectomy or hysterectomy. But sorry, in terms of how that would affect follow-up, I guess, again, most cases had hysterectomy and the aggressive ones had recurrence anyways. Yeah, I guess hopefully that
You
speaks enough
mentioned
to that question.
You mentioned the scenario of myomectomy specimens.
Yes.
So
Yes.
obviously an adequately treated IMT in a hysterectomy specimen is one thing, but you mentioned the scenario of a myomectomy specimen in a woman of reproductive age who may want to maintain fertility. I suppose my question would be, having read that paper and digested it and knowing it better than anyone here, would you be happy to say that yes, with the appropriate specimen, the appropriate myomectomy specimen, that's a low risk IMT, you can keep your uterus? Do you think you'd be, on the data you've got, do you think you'd be comfortable with that?
I think that's a really good question because, look, the paper itself doesn't obviously suggest that that was kind of one thing I took that we could possibly apply that for. I guess one of the key things I noted that was, I think, one case, the recurrence happened either somewhere along the lines of 8 to 10 years later. IMTs, I think one of my consultants had once said they should be classified as malignant. We shouldn't really think of them as benign. So it's a reach, but really in that specific scenario where women want to retain their fertility, it's a option potentially, with discussion, obviously, with the patient. But we can never say never, because the recurrence and the metastasis can just occur years later.
Okay, thank you. So, yeah, and I believe you had a question for Mahir.
Sorry, are you referring to me? I mean, I think
Yes.
Mihir had prepared some question for Mihir.
I have a few questions for all three of you. If I may ask, I won't ask all the questions because I think Rohan has already asked a few. So all three presented very well. I learned a lot today because you don't get time to read all articles, but because of this, at least you read the articles and you keep yourself updated with literature. So I'll start with Linda first. So Linda, in your paper, so you mentioned there were some, they did mitotic count. Was there any mention of whether they used Ki67 to see whether the Ki67 had any relevance with the proliferation activity in those tumors?
That's a great point. I mean, I had all the IHC figured out at one point, but then I just, towards the end of it didn't really, no, they did not. Sorry, no, they did not do a Ki67 and compare.
Because, leiomyosarcomas are rare. Amongst them, epithelioid leiosarcomas are quite rare.
Sure.
The problem sometimes people face is, when you get a frozen of what they think is a leiomyoma, and
Sure.
radiology, and suddenly you get this frozen, which looks there are mitoses. So we first and foremost struggle with whether it's a leiomyosarcoma or is it a stump. And then, so after reading this paper, when you get a frozen, are you going to try to see whether you can comment whether it's an epithelioid subtype?
Honestly, frozens, I like to play safe with frozen. So I would say, morphologically cannot exclude probable epithelioid, but I don't think I would just call it. That's a big call without permanent. I don't know if I would do that.
Yeah, I mean, frozen, I think
That's
gynae
pretty
pathology has its limitations on frozen, but of
sure.
course, depending on the country that you practice. When I was in the UK, we hardly did many gynae frozens, but come here every day we have a gynae frozen. So I think it varies the practice from country to country. Then
Sure.
was there any mention of, we use specific IHCs for trying to identify smooth muscle differentiation within malignant tumors.
Mhm.
Was there any IHC which was more sensitive than others in the context of an epithelioid differentiation within leiomyosarcomas?
It didn't really allude to that. It kind of just listed them all out as, these tumors expressed this panel. If I remember correctly, it didn't state like we did this one for this reason to, be a more specific marker. So they had obviously epithelial markers that they stained, but they didn't state why they chose that particular IHC
Okay.
marker. Yeah.
That's fine. Thank you. Okay,
You're
but
welcome.
Desmond, I have a couple of questions. So there was a slide which you showed that, there were tumors that were ALK positive on IHC. How many of were the cases which were ALK positive on IHC on which the molecular could not find the fusion?
No. There were fusions in all cases. Now, yeah, interestingly, they tell us that they only performed whole genome RNA sequencing on the cases where fusion wasn't found in DNA sequencing, but they don't show the data as to which cases required the RNA sequencing. But in the end, I believe as the table showed with the fusion partners, every case had ALK fusion. It's just that the aggressive ones had molecular alterations in addition to the ALK fusion.
So I don't know, maybe it is my inexperience, but the ALK, use of the ALK is sometimes when you see the morphology of the tumors, it looks like a smooth muscle tumor, unless you actually are quite particular in noticing the myxoid chains, inflammatory infiltrate, you might actually dismiss many of them as smooth muscle tumors. It is just now that we have been taught of this entity. Maybe so when you see any of those features, I have learned the hard way that maybe you should have a lower threshold to do the ALK stain. You might pick up the ones that I don't know how many I've missed in my career. So I think a lower threshold to use the ALK now, if you see the morphology and then you see all these other features, is probably, I don't know, what do Rohan and Yen think?
We have cases, I don't know if, Karen is here, Rowan. We have cases where it looks exactly like smooth muscle, but I think I have a very sharp colleague who chose, it doesn't have the myxoid look, it doesn't have really the typical inflammatory infiltrate, but they did the ALK and it's positive. But to be honest, if you show it round, it looks like smooth muscle. So I don't know if you actually do a lot of ALK immuno because we don't run the molecular on all cases. So if they are ALK positive, usually the typical one where the morphology looks like IMT, the ALK is positive, we will just call it. And it's only for those that, if we are not very sure, we need to confirm it, then we will do it. So I don't know. I've seen cases that to me look really like smooth muscle, but then it's ALK positive. So I don't know if you guys have this experience. I don't know if Karen, Rowan, you have this experience.
I have to admit, I throw a lot of ALK around, and so I have a low threshold for standing up a funny-looking leiomyoma. And you're right, you can certainly find cases that do have very much a smooth muscle phenotype. And they'll come back fish positive. So we would confirm ours with ALK fish as a rule. What I have found is that there's quite a different sensitivity between different ALK antibodies. So I try to stick to ALK1 as being the more specific. And occasionally you'll end up in a sticky situation where you will end up with an ALK positive IHC tumor but the FISH will be negative, and then you're really stuck, particularly if you don't have access to other molecular to sort of to go on and sequence or to look at RNA in that tumor, where the unit don't necessarily want to give you permission for that. So
Yes.
sometimes it creates more problems than it solves, but I agree with you. I've been surprised by some diagnoses in the past where the ELK was the only thing that tipped me off. So I have a low threshold for doing it.
Yes. I mean, pertaining your question to Desmond earlier about, if it's a low risk and you have a patient who wants to preserve fertility, what's the advice that you would give? And that brings me back to the category of stump, where, sometimes we have a myomag and then it's a stump and patient wants to preserve fertility. So what sort of advice do you give them? Like, do you say, you have to have a hysterectomy? Or, I mean, sometimes we advise the patient to get pregnant quickly, and then once they have a successful pregnancy, then to proceed on to hysterectomy. So I don't know if for the low risk, can we give such kind of advice? I mean, I don't know. Have you encountered such cases before?
We've been in that situation with a woman of reproductive age who wanted to retain fertility and had a IMT with low risk features, and that was exactly the advice. That she had the equivalent of a myomectomy, and it was now, please crack on, complete your family, and come back for a hysterectomy. And she was going to be watched in the meantime. So
Yes. Good. Can I just ask one quick question? I think we are like over the time, but to Linda, the cases that they class as a typical epithelioid leiomyosarcoma, they were saying that they use 2 points rather than sort of 2 criteria rather than 1 criteria. So for those that they class as stump or epithelioid, are they sticking to that particular criteria? Because to be honest, in practice, it's really, really tough if we encounter epithelioid smooth. So to me, it's not as straightforward. And I mean, we often struggle. What is atypia? What is diffuse atypia? It's really tough. So I'm just wondering, for their classification, do they strictly say 2 or more, or just like 1?
Yeah, that's a great question. So this paper did, I believe, recommend 2 criteria, which was kind of the big point versus like the WHO saying 1. And then I think once they got past morphology, they didn't even apply that criteria to those other lesions. So they just kind of threw them out of the study. So that's a good question. I'm not really quite sure what they did with those other lesions, but that's a great question. Not quite sure. It's challenging.
Yeah, it's
'cause
challenging.
I think their point was that in their series that once you drop the mitotic count down to the lower figure, they captured all of what they thought were epithelioid leiomyosarcomas. So even though their paper says you only need, they say, oh, you have 2 features. I think what the data actually shows is that all their leiomyosarcomas had 2 features, and I think back to return to your point, that means if you've only got 1 feature, not quite sure, because they only had 3 things they called E-stumps. So it might be that those borderline lesions are really, really rare with an epithelioid phenotype, but all of the thing that surprised me about this paper was how easy it was to diagnose most of these lesions as malignant. They all had 2 features easily, and so therefore you would easily put them in a malignant basket. So, and it might just reflect the fact that epithelioid change is a bad thing. So,
To be honest, for me, if I see epithelioid, actually my threshold go down quite significantly, because I
yes,
just get worried that they are going to be aggressive regardless.
definitely.
Yeah.
Mm.
Here, you want to continue? Sorry to interrupt.
I don't know. I think I
Well,
don't know how much time we have. So, of course, Meher, we have to ask you a question also. Can't forget you. So, Meher, you already presented this thing to me previously. So, one of the questions I had for you is, the Pantract IHC, because it's a targetable lesion or targetable tumor. So it's something similar like HER2 IHC. Okay? HER2, you do the IHC stain, the IHC is 3+, the patient can go on Herceptin. So Pantract, of course, is not that way. The IHC is not equivalent to an HER2 IHC in the sense you still, for every of these tumors to have the targeted therapy, you have to do the molecular testing, right? So I don't know. Do you know the difference, the cost between doing a molecular versus an IHC stain?
Yeah, I tried to look into it. I couldn't find any definitive numbers, but obviously, yeah, IHC is much cheaper. Like it would sort of be in the sort of hundreds rather than molecular would be in the thousands. So yeah, it's definitely much cheaper, which I think is why, you know, for gold standard diagnosis, you'd molecular everything. But we obviously can't do that realistically. So I think that's why they're really trying to get a use case for pan-track IHC and get it to a point where there's clear criteria for yeah, like you said, like, you know, like HER2, because yeah, that's the best and most efficient screening tool we have without going straight to molecular, I think.
Because, you know, I've not seen many in the cervix, but I certainly have seen people presenting, because we also have a children's hospital here, and pediatric patients where, of course, you know, there's a lot of emotion attached when it concerns a pediatric case, a child's case. And some of these tumors actually shrink very rapidly if you give them the targeted therapy. So I
Yeah.
think in cases where, you know, they try and the tumor continues to grow, then you probably have to think of this, if you haven't thought of it in the first instance, for high-grade sarcoma of the uterus or cervix. So I think targeted therapy has different implications because it affects direct patient management.
Yeah,
Then I had a
definitely.
question for Desmond, which partly has been already addressed, I think. So, you know, clinicians, as pathologists, we are very keen. We try to separate, try to do a lot of IHC. Clinicians are quite, they just want to know whether, you know, treatment-wise, how is the treatment going to be different? So in the paper somewhere, did they say the ones that were aggressive, from what criteria they used, how differently do they behave from smooth muscle tumors, for example, like a stump or a smooth muscle tumor, which is not highly aggressive? Do ALK positive, no, ALK positive tumors, how differently do they behave stage to stage with any smooth muscle tumor of the same type?
No, the paper doesn't make any direct comparisons, comparisons to other tumors. And in fact, they don't actually really go any further beyond that stratification score as to how differently a low risk and a high risk actually behaves. It's kind of just, can it, have that extrauterine presentation, recurrence, or metastasis. They don't make any comparisons per se. So I guess it's kind of in its own context, the low risk and high risk IMTs. And again, they don't propose. So I guess but the point of this whole molecular discussion is that they don't want an intermediate risk stump equivalent of an IMT. They just want to put it into that two-tier system, low risk and high risk. So no, I guess it's what's given from the paper. You can't really compare it to the smooth muscle tumors, which include that intermediate category of a stump. So no, the paper doesn't answer that question.
I have no more questions.
Well, I think as Ian mentioned, time has got away on us, so I suppose we should draw to a close. I'd like to thank our three speakers and also all my co-moderators. This has been one of the most interesting discussions we've had about a series of papers, and I really think that reflects the quality of the presentations and the presenters to provoke those questions. And I must say you've been well and thoroughly grilled. I think you all deserve a drink. So don't forget, next month we'll be coming to you from the Western Hemisphere Journal Club in October. Thank you for joining us, and we'll sign off.